important. That's why initial diagnoses are often very inaccurate, because sometimes you just can't tell. It takes time for these things to roll out, so to speak, because they're problems within problems within problems. And people regress when they come to treatment. They're supposed to. We call it regression in the service of the ego. When you come into treatment, there should be some kind of regression going on. And when the ego regresses and defenses come down, then you start seeing all sorts of stuff that you wouldn't see if the person was out working in the day-to-day world and going on with their life. But it's certainly, I don't know if that answers Dr. Joe's question, but it's certainly something that we see on a regular basis. And that the test that we use is pretty good at picking up on somatic complaints. And they're tough problems to treat. Somebody's convinced they got physical problems. It's easy for them to say, you don't understand. This is what it is. Or, if it's a hysterical or hysteroid kind of situation, it's embedded in the person's psyche. It's hard to reorient their awareness to that it's not that. Much harder than somebody who comes in, blames all the problems on something else, and they come in, they realize that most of it is addiction related. That's relatively easy to do in contrast. Okay, components of treatment, I think we do all those. I think care is state of the art. I should be going around the country training people in the Karen model about how to do treatment, because I think we do a good job. Would you agree? Much has been made of this matching thing, to bring somebody to a program and to fit the patient to the program's treatment is not the way he's supposed to go. He's supposed to match the appropriate treatments based on the treatment plan. And I think we pretty much do that here. When I sit in treatment team meetings, I don't think we come in, there's only one way to do this problem and the patient's got to mold themselves to it. I think we're pretty good at working with this matching treatment, which is supposedly state of the art in the treatment of dual diagnosis. I'm going to skip over the strategies to improve adherence. The other thing I'll say about that is most patients don't adhere to treatment recommendations. How many times you go, you or anybody going to the doctor says, I want you to lose weight, stop smoking, and start exercising. Yeah. And then 2 weeks later, you're back there, you're sitting on the couch eating Doritos and watching somebody's exercise video, watching it rather than doing it, and smoking a cigarette. It's very hard to change behaviors, and I mean, there are hard behaviors to change, but in terms of, going to meetings, doing the things people are supposed to do requires constant motivation. Maybe we should have addictions motivation counselors to help people stick to the program when they leave here. I don't know, maybe a whole other profession, a whole other certification. But at least when it comes to medicines, there's a lot of non-adherence and non-compliance with medicines, and that's serious business. And so I think if a patient sees the rhyme and reason to it, if you explain to the patient, this is what this medicine does, and this is what this treatment does, and this is why you need it, and this is what will happen if you don't, a lot of compliance problems can, be significantly reduced. Somebody doesn't know why they're doing something and doesn't see the mechanism involved, and it's easy to go, well, I don't know what, I'm just doing it as I was told to. So, of all the treatment adherence strategies, that's the one to me which is most important. That the person has some sort of rhyme and reason why they're doing what they're doing, and what are the downside if they don't do it. It's easy to control the treatment adherence in inpatient because you have a treatment plan, you either do the stuff or you don't do the stuff. So it's harder in an outpatient setting, which is where everybody's going when they leave here. We're kind of in a little bubble here in some ways, It's more defined, and there seems to be closure on things, and then people, it's a different story when they leave. Treatment of depression. As I mentioned previously, depression is a common disorder, and it responds well to treatment. And it doesn't have to just be cognitive therapy. it responds to any kind of therapy. Studies are now showing that depression raises your chances for cardiac problems, all sorts of diseases. It really is a disease as much as addiction is a disease or any physical disease is there. One study suggested that depressed patients' platelets get sticky, so if there's some kind of damage to the arteries, the body's response to it is less, and they're more vulnerable for heart attacks. Immune system function is depressed in depressed patients. So anything that you can do to get somebody moving out of depression and functioning is important. The thing that I see mostly that's disturbing to me, somebody will come in here and they'll be on Paxil, they'll be on Prozac, was given to them by a primary care provider, and they never had any therapy for depression. Looks like taking antabuse without, treating alcoholism. And that's a common scenario. People get well from depression by reconfiguring and relearning how to do life. And that's what comes from psychotherapy. There's always sophisticated brain studies going on now, and I'm going to talk a little bit about them when it comes to spirituality. But they're showing now that psychotherapy produces permanent changes in the brain. Anything that you do, if you learn a new skill, you have a new experience, produces changes in the brain. The brain is a very malleable instrument and can be changed, can be reconfigured. So it's important for patients that have had panic attacks or have depression or have whatever the problem is, post-traumatic stress disorder, that they get some therapy. And, most aren't now. Because that's the downside of the new wonderful medicines, is that's all people are doing. Yeah, but I've had Paxil for 10 years now. Did you ever talk to the counselor and they go, nope, what do I need that for? I mean, it's problem solving. What happens if, Paxil runs out, here in Australia or something? And there's now some patients aren't interested in that. I get my Paxil, I don't need a psychotherapy. It's expensive, and what's it all about? Feelings and all that. I don't go for that. And they don't want to go to it, and they're not going to go to it. And that's what it's going to be. But I think the patient's going to be in a much better position if they get involved in some serious therapy. And it doesn't even have to be long; it just has to be a couple of weeks. Okay. Under anxiety disorders, I'll just say that I always feel bad for patients who have severe anxiety disorders, and they also happen to be an addict, because there's not much less one can do pharmacologically. But every patient with an anxiety disorder, to me, should be meditating on a daily basis because of the powerful changes in the autonomic nervous system that come about from that technique, and should be involved in some type of treatment because they're treatable problems. Schizophrenia, I'm going to kind of go over or skip because I think that it's not a common problem here. Under personality disorders. Alcoholic males are 4 times as likely to have antisocial personality disorder than non-alcoholic males. Borderline personality disorder is common. Personality disorder addicts are characterized by an earlier onset of the disease, greater severity, polydrug dependence, poorer outcome, greater levels of suicidal behavior. About half of alcoholics and close to 2/3 of addicts have a personality disorder. And that always complicates treatment. Now, some of the same 12-step approaches work for personality disorders, particularly work on character defects. I want to talk a little bit about female patients. Do we still have gender-separate and gender-specific treatment? Do we? I know a couple years ago we instituted it, but I'm not on my hand on the clinical pulse. Okay. Right, and that was in response to all this research showing that there's very different, that there's a divergence in terms of problems and treatment approaches for male and female patients.